This follows on very nicely from Robbie's great example about dealing with equity issues and using their data. And I was standing next to Wee talking about that and looking at the tools and the data and the starting to understand of the system. And I have to say, I wrote him a little note saying, wow, this is what success starts to look like, about using those tools and where you're going and starting to understand the system of care and how you start to go about changing it. So this wasn't, Natalie is unfortunately not able to join us, but we and I will pursue and carry on, and we'll talk about a little bit more about equity, data, change ideas, and application, about thinking about how do we go about, what are the ideas and how do we go about learning from our system and our data about changing what's currently happening. So overview, we hope that you understand the extent of which inequity occurs in our system of care for mental health, what our data is currently showing us and what we can learn from it and how we can look at our system. We'd like you to go away thinking a little bit more about how do you introduce those change concepts into your theory for change in your driver diagrams, and how you can use your data around that and learn about your system. So one of the key points that I think I wanted to link in this is about when we talk about quality, we talk about 6 domains of quality. Okay, and there is no quality if you've got 3 out of 6 or 4 out of 6. It's about 6 out of 6. And so that healthcare needs to be safe. It needs to be effective. We need to do the right things. It needs to be around what patients, family, patient-centred. They are at the centre of what we do. They're our North Star. It needs to be timely. We need to be able to address people's needs in a timely fashion. It needs to be efficient. We need to not have waste in the system and doing things that don't add value. And it needs to be equitable. And so you can't really say that you're focusing on quality if you don't put this lens over quality. I've come across this and some really interesting work coming out now around and addressing equity in healthcare, and I think this is a really useful thing to think about, and there's some new tools that we'll have out and share with you as we go through the process. But reducing disparity requires attention to essential components of equitable patient-centred care. It needs to be patient-centred, it needs to be high quality, which is all those domains of quality, and that is that there are culturally and linguistic components of care that you need to think about in your quality of care, and we also need to pay attention to health literacy around that and think about different patient populations that you're dealing with and that you have health literacy. And I think Robbie's demonstrated that beautifully for us. So talk a little bit about the data that we have to date. And this is national data. So what we're seeing now is nearly half of all consumers who were secluded on admissions were Māori. And when you look at Māori and Pacifica, it's over 50% of the population. So if we're thinking about our journey towards zero seclusion, we are going to have key strategies and change ideas and change the service to achieve zero. Māori are much more likely to be secluded of people admitted to mental health units. They're twice as likely to be secluded than non-Māori. And it's interesting that your data reflects that as well, and some of the other DHBs that we've seen clearly reflect that. And we see that this is the national picture, but then you can go back and look at your own information. Some of the data that we've looked at in the past is looked at per population, but this data specifically, when we talk about twice, is about patients admitted to mental health units or consumers admitted. So we've also done some work, and Tapo's been very strong in this, about starting to understand why is this occurring? Is it related to patient characteristics or what's going on around that? Are there other reasons, or is it purely an ethnicity issue? So there's been some work, and they've adjusted for variables, and they have still found that this is actually an ethnicity issue. It isn't definitely other patient population things. So they've done a lot of work and looked at all those different variables, and still what they've come out with, it's not the patient cohort, it's actually an ethnicity issue. I think that just gives us a little bit more context of where the data is talking about. And I'm just going to follow a little bit of if you want to know more about this around that is, Natalie's notes is about what I want to explain is, Māori are secluded at over twice the rate of non-Māori. Other statistics in the sector say that Māori are secluded over 4.5 times of that of non-Māori. So why we present this is because we are focusing specifically, when we talk about 2 times, it's because we're focusing not on the population, but we're looking at the population that we have action on, and that's around the inpatient units that we're focusing on. Does that make sense? So when you see different data and we talk about different numbers, just understanding the context of which we're talking about. So we're looking at where we're taking action, and that's in inpatient units. And I think at this point I'm going to hand over to Wee to talk about some of the things that they've learned around what's contributing to that.
So many factors contribute to higher seclusion for Māori. One of the ones that has high impact on us all, I think, is the first one, which is unconscious bias. We all have unconscious bias. I have unconscious bias towards Japanese cars, right? I like Fords. And I'm depressed that Fords are going out of fashion. So it means I may have to consider buying Asian originating vehicles. But seriously, we all have these biases. And we need to, when we're dealing with people from other cultures, we need to think about this and whether or not these biases we carry with us anyway are affecting the way that we develop our relationships with these other ethnic groups. Looking at your stories on the walls, I can see that you're connecting now with your kaupapa Māori services throughout your DHBs. We know that each DHB actually has a kaupapa Māori mental health service. How effective the relationship is between them and the mainstream services, I think is an area that we all have to work on. The evidence is very clear. Unless we are looking at incorporating kaupapa Māori into the project teams and the co-designed systems that we're developing, we're never going to reduce inequity for Māori. Pacific Island, we would say the same thing. Unless you're incorporating Pacific Island models into the co-designed work that you're doing, you may never reduce Pacific Island inequity. So I can't, in all seriousness, I can't minimize I can't impress on you how important that is if we want to make headway into the huge block that we have where Māori are ending up in seclusion. We've always done things in a particular way, and I know that I'm talking to people who know this already. I know how difficult it is to work in mental health and addiction teams when you're at the edge, when you're at the sharp edge. I've been there myself. But I've always said that, we have to be brave, have to be courageous, and if we want to make impact in this area, we have to push the need for cultural bundles of interventions to be included in the mainstream interventions, because, quite simply, the mainstream ones aren't working. For Māori, for Pacific, we need to be more innovative, more creative. And here we see the wide range of variation by DHB in rates of seclusion. This is another thing that's difficult to understand. Supposedly, we all come out of the same training establishments. The guidelines and the training are the same for teams all over the country. And yet, there is that much variation going on. I'm not used to following slides, by the way, you can see that, can't you? No variation between DHB seclusion use is due to differences in organisational culture. Yeah, well, we've just been talking about that, haven't we? The people on the afternoon shift and the evening shift often are difficult to bring to in-service training, so they may apply things in a different way from the teams who are on during the day. But we need to contact those people. I'm talking about what used to happen 20 years ago, by the way, when I was a psych nurse. Is it still the same? Well, that's the culture we need to get rid of, guys. It's got to go. And this is, what do we know about DHB cultural competency? Well, you might have all participated in the Ngā Poutama survey, where we posed 4 questions from the Māori advisory group that if responded to by staff in mental health services throughout the country would give us a good indication of how well kaupapa Māori was being practiced in district health boards, in the mental health services and in NGOs as well. We got a really good response from the Māori units, from Māori who worked in the Māori units, not so good from Māori who were working in the mainstream units. So what that tells us is that we need to include, as I said at the start of this presentation, of my bit, we need to include kaupapa Māori services in the work that we're doing. So please do engage with them. Those are the 4 questions we asked. There's no need for me to explain that. Keep on going. Yeah, what the information tells us is that Māori are a huge factor in the use of seclusion. And if we really want to bring down seclusion, the proportion of people being secluded, the percentages, then Māori are the obvious group to target for this. Next one. What can we do? Well, a lot of you are already doing that. You're considering using kaupapa Māori interventions in your services. I can't say enough about the positive involvement of whānau. Being a whānau member of a young person who loves to use addictive substances, and no matter how sensible you try to speak to this young fellow about it, he says, "Are you sure you know what you're talking about?" And if it wasn't for the intervention that we have as a family, or our understanding of how mental health services work, he would have ended up in seclusion every time. But we managed to get a deal with the staff on the wards, and we have a good relationship with the psychiatrists. So one of us is always with him whenever he's going through the services. So the positive involvement by whānau and allowing whānau to have positive involvement is really important. This is the model that we're testing at the moment. The model for improvement, which is based on the 3 Ps of the Treaty of Waitangi. You all know that, don't you? Partnership, participation, active protection of Māori healing strategies, etc., and co-design. So it's bringing together Māori concepts, the equity framework, and Western biopsychosocial concepts inside the co-design plan, study, do cycle, with all of the right stakeholders involved working together, exactly what Robbie's talking about actually, to produce good results. So thank you very much. Hope that was helpful.
So when we started thinking about this, we wanted to try and think about how would we incorporate these change ideas into our theory for improvement. So we have done a bit of work and a bit of putting our heads together and learning from both what you guys have been doing and our discussions across our teams about what would a driver diagram look like. So on your tables and up on the screen is an example of a driver diagram looking at equity issues in relationship to zero seclusion.